Very good morning to all of you. I'm Dr. Vishwas Sade, Professor in Anaesthesiology at MGM Medical College. And thank you, sir, for the introduction. We'll be talking about, rather interacting, about the role of the anesthetist when it comes to the high-risk cardiac cases. I think what we've seen over the talks that we've just heard is that the anesthetist has evolved as as an important stakeholder in whatever advances medicine is offering, and the anesthetist is nowhere behind when it comes to being proactive in the management of the patient. And when we look at the newer gadgets and the newer advances that are at our disposal, I think we have a great future and a great responsibility on our shoulders to take that forward. So on that note, I will start my talk. It's about advanced hemodynamic monitoring in high-risk cases. So before I start, a disclaimer: this is purely an academic activity, no endorsement, no conflict of interest, and no financial agreements with any agencies whatsoever. So when we talk about hemodynamic monitoring, we just come down to the basics. What are the aims of hemodynamic monitoring? We want to maintain euvolemia. We want to detect or preemptively detect hypo or hypovolemia and take corrective action. Then we try to target ourselves towards goal-directed fluid therapy. The whole point of this all is to maintain that critical balance between the oxygen demand and the supply. So that's what with the advent of advanced hemodynamic monitoring, this is becoming not 100% secure, but then we're getting closer, and there's never any stopping that. So what are the factors which affect the hemodynamics? We all know this is all what we've learned all our life. So we know that it depends on the preload, it depends on the myocardial contraction and the heart rate, and it also depends on the afterload. These are the basic things which we all know. But then how do we monitor them better so as to be an effective anesthetist? So there comes the role of the newer interventions. I'm not going to talk about the basic ones like the CVP because this is a small talk, but important ones that the PA catheter, that I think revolutionized the way we started managing, and it threw us enormous numbers which could be derived and then acted upon. So if you have a look at the list, it could give us the CVP, it gave us the PAOPs, the cardiac output and the index, the stroke volume, and all these parameters. And all these parameters give us a plethora of information which can be acted, and if acted at the right time, it can definitely influence the way the patient behaves in the OR, especially in high-risk cardiac surgeries. So most of these, some of these are also surrogate indicators, like your PAOP, the occlusion pressure is essentially a surrogate indicator of your left ventricular end diastolic pressure. The cardiac output is derived by thermodilation, and your mixed venous oxygen is basically your oxygen delivery and uptake. So now, if let's just look at it in a clinical scenario. We have three kinds of patients. If you look at it on your left of the screen, there's a patient who has probably, who has a PA catheter in place and who has low CVP, low cardiac index, and high SVRI. So how does this help us, determine what to do with this patient? So any students at the back? So with the left patient, this one, the patient has low CVP, has a low cardiac index, and a high SVRI. So the most obvious thing for this patient, looking at these parameters, would be to consider fluid challenge, because it looks like this patient is hypovolemic. Similarly, going to the next scenario, if you look at it, this patient has a high CVP, a low cardiac index, and a high SVRI. So the fluid is not a problem clearly in this situation, but the contractility seems to be an issue. So obviously, with this kind of information, we would think that the cause for the hypotension is probably cardiogenic, and we would consider inotropes. Similarly, if you look at the next one, which has low CVP, high cardiac index, and low SVRI. So in this kind of patients, we know that the CVP is low, but his SVRI is also low. So that probably that the patient is dilated peripherally and he needs peripheral vasoconstrictors or vasopressors. So this is how advanced hemodynamic monitoring has made it so much easier for us to look at individual scenarios, get the numbers on your monitor and act on those numbers. But obviously you also have to look at the patient clinically and not just treat the numbers. But the numbers do serve as an invaluable guide for us to manage the patient intra-op. So mixed venous saturation is just measured in the pulmonary artery blood. It's the difference between the whole body delivery and what the body consumes, and the formula we all know. So this the delivery is influenced by your important parameters like your cardiac output, the hemoglobin, and your saturation, arterial oxygen saturation. So therefore your mixed venous saturation is thereby affected by your cardiac output, your hemoglobin, your arterial oxygen saturation, and the consumption. So these factors also give us an idea about what is really happening. Are we supplying enough oxygen, or is there more consumption of the oxygen, and if so, why? So the normal mixed venous oxygen saturation is around 70 to 75%. Now again, coming back to a clinical scenario, if you look that there is decreased mixed venous oxygen saturation, what it means is that probably there is more of consumption, the body is hungry for that oxygen, so it could be due to pain, it could be due to hyperthermia, or there could be a problem with the delivery of that oxygen due to reduced cardiac output, anemia, or hypoxemia. Conversely, an increased mixed venous oxygen could mean that there is an increased delivery, high cardiac output, hyperbaric oxygen therapy, or then there could be low consumptive states like sedation, paralysis, or toxicity. So these were the parameters which are given to us by the PA catheter. And if you look at all these studies, PA catheter does not serve as an independent indicator or a predictor of mortality. It is an invaluable equipment. It is an invaluable piece of equipment. In fact, I still use PA catheter in all my cardiac cases. But then, like I said, it can't be just one thing, and obviously there are going to be other factors which we may have to consider as we advance in the medical field. So these are the advances that are now at our disposal, and which, if used properly, can definitely influence better patient survival. So the first one that I'm going to talk about is, does anyone know what this gadget is? There is a small device there on this catheter. Yes. So it's using the thermodilation method. So what it does is, essentially, if you look at it, it's very simple, it's all physics, it's just simple. What it means is that your cardiac output, how does it measure the cardiac output? There is a heat sensing device. It just, measures the temperature gradient between the device. The time taken for that temperature to change, it depends on the flow. So if you look at it this way, so your cardiac output, if it's increased, that means there is increased flow over the device, and that means there is increased requirement of power to maintain that gradient. So this is just the way the technology has been used to just translate this information into a continuous cardiac output numeric. Conversely, on the other end, if decreased cardiac output means decreased flow over the device and decreased power required to maintain the gradient. So anyone? What is this is? The students? This is also something which we use very commonly now, is the PICO device. This again works on the simple principles of physics. If you look at the screen, there is an injection being given in your central line or your PA catheter at the top, okay, which is at a specific temperature, and then it is collected down, if you can see the round arrow, in your peripheral arterial cannula, and it is then plotted over a graph. So what it does is that it just sees the temperature change when it has been injected at the top and when it is collected at the bottom, and it is plotted on a graph. The time taken for that temperature change also means that it also gives us an idea about the velocity, which is then translated into your cardiac output, because your cardiac output will clearly influence the velocity of that flow. So to explain it, after central venous injection of the indicator at the thermistor, the tip of the arterial catheter measures the downstream temperature changes. So the cardiac output is calculated by analysis of the thermodilution curve using the Stewart-Hamilton algorithm. So that's what I was explaining. It's just the temperature when you inject, it just goes up, and then as it goes into a downslope, it is discalibrated. This is again calibrated over your arterial line pulse contour analysis, and by using the algorithm, we are able to derive the cardiac output of this patient. So what does a PICO do? It gives us numbers, so many numbers that sometimes even we don't know which ones to look at. So if you look at it, the thermodilution parameters that can be derived using the PICO technology is your cardiac output, your global end diastolic volume, your intrathoracic blood volume, your extravascular lung water, your pulmonary vascular permeability, and also your cardiac function index and your global ejection fraction. So these are, lots of information to analyze. And what is important as an anesthetist is to be able to analyze this information and then act on it effectively. It also gives the pulse contour, which is your arterial catheter at the other end, also gives the other derivatives like your pulse contour, cardiac output, your arterial blood pressure, your heart rate, the stroke volume variation, pulse pressure variation, and your systemic vascular resistance, and also the index of left ventricular contractility. So many parameters to look at and so many to analyze. So how do we use them? So for that, you need to understand the basic, what exactly is happening. After injection, the indicator passes through the following intrathoracic compartment. So if you look at it, as a whole figure, it basically goes from your right side of the heart into the lungs and comes out of the left side of the heart. And the right side, you have your bolus injection. At the left side, you have the arterial catheter, which will then measure it via a thermodilution curve. So the intrathoracic compartments these compartments can be considered as a series of mixing chambers. So the temperature at which the injected is injected and it's collected, there's a change in temperature, and that change is also affected by your cardiac output. So the largest mixing chamber in this series is the lungs. Here the indicator has its largest distribution volume, which is the largest thermal volume. So how do you calculate these volumes? What is the physics behind it? When I started studying medicine, I thought that that's the end of mathematics. I don't have to look back at my maths again. But then I was unfortunately very wrong, because the more you progress, the more you realize that you can't escape maths. So then it boils down to this, how do you use that calculation? So the calculation of volume, so the intrathoracic thermal volume is basically a product of your cardiac output over the mean time taken for that solution to injected to come from your right side of the heart to the left side. So if you can look at the diagram, this is what the mixing chambers I was talking about. So that entire thing is your intrathoracic thermal volume. The other parameter is your pulmonary thermal volume, which is again your cardiac output versus mixed with your downslope time. So this is what it is. The global end diastolic volume is the difference between, if you can look at the picture, it probably will make more sense now. It's the difference between the intrathoracic thermal volume, which is all your mixing chambers, and minusing the pulmonary thermal volume. So that is your end diastolic volume. And all these parameters can be acquired using your newer technologies. And if you look at the last one, intrathoracic blood volume is basically multiplying the GEDV by a constant of 1.25. And your extravascular lung water, which is again an important indicator is basically the difference between your intrathoracic thermal volume minus your intrathoracic blood volume. So if you can see that that's basically an indicator of, how much fluid are you talking about when it comes to your lungs. So these are the number of values that are thrown at us, and utilizing these values and acting on it is more important. So if you look at the next slide, so if you just take the pulmonary vascular permeability index, so it's basically the ratio of the extravascular lung water to pulmonary blood volume. It identifies the type of pulmonary edema like I was talking about. So if you look at this slide, okay, so look at the extravascular lung water compartment and the pulmonary blood volume. So in this case, in this reference picture, they seem to be normal. So if your pulmonary vascular permeability index is normal, what it means is that extravascular lung water is normal and your pulmonary blood volume is normal, which is the case in a normal lung. However, now if you look at this, there's a change in the picture. So what has happened over here? If you look at this, your pulmonary blood volume has increased and also your extravascular lung volume has increased. So what has happened is that your alveoli are probably inundated with fluid now. So why that has happened is because of your increased hydrostatic pressure. Okay, so that is the cause of the pulmonary edema in this situation, where you can see that although your permeability is normal, there is no problem with the permeability, there is no pathology in that, but because by the sheer increase in the volume, the hydrostatic forces have created pulmonary edema. If you look at this picture now, you will see that the pulmonary blood volume is normal, okay, but your extravascular lung water is increased. So what that means is definitely that your permeability has gone for a toss, and in this situation we have a pulmonary edema because of the damage to the permeability. So like I said, it's not very difficult to understand. It's just applying a little bit of math and a little bit of physics to what we do every day, and that's why the newer advances are I think a very efficient guide to proper management of patient care. Similarly, if you look at this global ejection fraction, it is basically, just to summarize, it's just basically a combination of your right ventricular ejection fraction, which you are deriving by using your thermodilution method, and your left ventricular ejection fraction, which you can derive using your normal echocardiography. So if you look at that, the sum of both of these will give you a global ejection fraction, which can be derived using a thermodilution method. The stroke volume variation that I was talking about is basically represents, the variation of stroke volume over the ventilatory cycle. So it's basically if you measured over a 30-second window, but it has its limitations. It is only applicable in mechanically ventilated patients who have a regular heart rhythm. So all these parameters, when you look at the numbers, you also have to know what are the normal numbers to look at, because just getting a number on the screen is not going to be enough if you don't know what is the normal range for each of these values, which we will discuss in the next few slides. Again, pulse pressure variation represents the variation of the pulse pressure over the ventilatory cycle, somewhat similar to the stroke volume variation. It is also measured over a 30-second window, and also the limitation is the same. It is only applicable in mechanically ventilated patients with a regular heart rate. Another parameter is the index of your left ventricular contractility. It represents your left ventral pressure velocity increase, and thus is a parameter of your myocardial contractility. So what it means is that if the contractility is better, if you look at the slope of this curve, it's quite steep. So that indicates that your contractility is good. So now, I threw so many, numbers at you, and I show so many of these, abbreviations. But how do we apply them clinically? We have a cardiac output, we know the GEDV, we know SVV, we know SVR, we know extravascular lung water. How do you actually implement them? And what do you give? Patient is not in a good situation, patient is probably hypotensive. How do we decide, do I need to give volume, do I need to give drugs? I have so many information, which one of them to use when? So first of all, ask these basic simple questions. What is the current situation? You want to know the current situation? Look for the cardiac output. Okay. What is the preload? You want to know the preload? Look for your global end diastolic volume. Now, will that cardiac output improve after giving volume? Look at your stroke volume variation. What about the afterload? If you want to know about the afterload, look at your systemic vascular resistance. And what about the lungs? Are my lungs still dry? Look at the extravascular lung water. So these are the questions that you should be asking, and if you keep on doing this on a regular basis, you will not need to memorize them or click pictures, because then they will be at the back of your head, because every time you ask these questions, these are the indicators that you will start looking for, and the minute you start looking for these indicators, you will start knowing what is the normal range for these indicators. So the references for PICO is that it's been quite well documented that the global end diastolic volume and the intrathoracic blood volume have shown to be far more sensitive and specific to cardiac preload compared to the standard cardiac filling pressures, CVP plus PCWP, as well as right ventricular end diastolic volume. The striking advantage of GEDV and ITBV is that they're not adversely influenced by mechanical ventilation. Extravascular lung water has also shown to have a very clear correlation to the severity of RDS. It has also helped us, get an idea about, the length of the ventilation, your ICU stay, the mortality, and using the parameter of EVLW is shown to be superior to assessment of lung edema versus chest X-ray, and it definitely clearly indicates fluid overload. So if you look at the mortality figures, mortality as a function of extravascular lung water in 370 critically ill ICU patients, if you look at that, it's definitely shown that it is an important parameter when you look at the number of ventilation days, the ICU stay, and the mortality. The mortality has definitely changed in terms of when we started using EVLW. So what is the relevance of the extravascular lung water management? If you look at that, the left side, the yellow one is the PAC group, the PA catheter group, and as compared to that, the right side is the extravascular lung water group. So if you look at that, the ventilation in the PA catheter group was almost 20 plus days, whereas the extravascular lung water group was around 9 to 10 days. And also the ICU stay was markedly reduced when we're using the extravascular lung water as one of the tools of management. So to code this, 101 patients with pulmonary edema were randomized to pulmonary artery catheter management group, in whom fluid management decisions were guided by PCWP measurements, and 2 an extravascular lung water management group using a protocol based on the bedside measurement of extravascular lung water. ICU days and ventilator days were significantly shorter in patients of the extravascular lung water group, unquote. Also, stroke volume variation and pulse pressure variation are excellent predictors of volume responsiveness. Obviously, they have their limitations. Like I said, they work more efficiently in mechanically ventilated patients and patients who have a regular heart rate. But to quote this study, the CVP cannot predict whether volume load leads to an increase in stroke volume or not. Traditionally, all we used to do is that just look whether the CVP is low and then just push in some fluids. However, these two parameters with the limitations, the riders that I just spoke about, are excellent predictors of volume responsiveness. So this is what I was talking about. These are the normal values that when you start using these indicators over a period of time, these values will just be at the back of your head, because if you start using them on a day-to-day basis, you won't have to refer. But for the young trainees, what we do in our ORs is that we keep a chart next to our monitor where they can refer to this, because the more you see, the more you learn. So these are the normal values that you use. This is an interesting tree, but I don't think we have time to go through this decision-making tree. But just to give you an example, Looking at, your cardiac index, less than 3, there seems to be an issue, problem is there. Your global end diastole index is less, or your intrathoracic blood index is less, so that means there is some problem. Your extravascular lung water is less than 7, so that definitely means that this patient is not in pulmonary edema. He can respond to volume. Similarly, if you look at the other side, your extravascular lung water is more than 10, which is above the normal value. You can give fluids, but with caution. This patient would rather require catecholamides. So this is how the tree works, and it's, maybe at a later point